I have the honor of introducing Teresa Lanza today. She was born and raised in Italy and, in fact, did her medical training in psychiatry in Italy, where she met a mentor who introduced her to the work of Viktor Frankl. She's always had an interest in anthropological and a philosophical uh, uh, aspect of things. And she kind of had logotherapy in the back of her mind for many, many years, as she explained to me. And when she came here recently, when she came here, after a few years, she decided to pursue logotherapy, which is what she's done. She is almost done with the coursework and headed soon, we hope, into a diplomate project. So her training is classical training in psychiatry with the classical psychoanalysis, as well as cognitive behavioral therapy and acceptance and commitment therapy. And that's the latter. Acceptance and commitment therapy is what she's going to connect to logotherapy for us today, or more correctly, connect logotherapy to ACT. She's currently in private practice in Austin, Texas, and she is an affiliated faculty member with the University of Texas at Austin in psychiatry and women's health. So with that, I would like to welcome Teresa.
Thank you very much, and good afternoon to everybody. And thank you incredibly to the committee for this opportunity to share some thoughts and reflection in this very important venue. So I will hopefully, I will move on. In this presentation, I will start by referring to some current data that suggests that the discourse around meaning in life constructs matters particularly today. I will then move to summarizing key aspects of acceptance and commitment therapy, and I will then try to elaborate on how logotherapy and ACT, that's the acronym for acceptance and commitment therapy, may integrate from a theoretical standpoint and then probably in clinical application. And it is my aim to leave time for discussion and mostly really learning from you all what you think about this, what lessons you can teach us about integration, not only with ACT but also with any other paradigm that you may see useful. The problem of completed suicide, which is really the ultimate no to life, is still an incredible big problem, is a public health concern. These are recent data from the CDC in the United States. And what is particularly alarming is that, particularly in the young age, suicide ranks among the highest and the most frequent cause of death. And looking at
Dr.
data,
Lanza, do you want to share your screen with us? Share your slides?
Okay. Sorry.
Sorry to interrupt.
Yeah, no, sorry, I didn't. I'm sorry, I thought that I did that. So, share screen. Thank you, I'm sorry. Okay. Can everybody see?
Yes.
Okay, all right. So this is the table reporting the data I was referring to about the CDC. So suicide is still very, very high in terms of frequency.
I'm sorry to interrupt again, but could you start the slideshow version there as we did before? My apologies. Thank you. No. Perfect.
Okay.
Perfect.
That it work? Okay. Thank you. All right. So this is the outline I was referring to before. And this is the table with the data on suicide in the United States from the CDC. That is alarming, especially if we look at a young age. And over the years, really the data on suicide in the United States have not significantly improved across age and in both men and women. And we are probably aware of the recent advisory of the US Surgeon General that points to loneliness and isolation as a public health concern and really raise attention to doing something about connectedness. And this really made me think about how important it is to discuss about, for example, the experiential values that Frankl talks about. So the importance to transcend and connect in experiences with others. Even within the healthcare field, the issue around meaning is becoming more and more of interest because of its linkage to burnout and compassion fatigue, until the time when in 2017, actually, the national organization that supersedes the education of physicians in the US changed the program requirements. And now every residency program in the US needs to do something. It can be very individual to improve well-being of residents, but as with the ultimate goal in rediscovering joy and meaning in work. So dialogue around meaning is very, very alive, and the need to do more and build on the strength of what Dr. Frankl gave to us and left to us is, I think, essential. So acceptance and commitment therapy is a transdiagnostic treatment approach that was developed at the beginning of the 80s by Stephen Hayes at the University of Nevada and colleagues, which is based on traditional behavioral therapy as well as third wave methods. And from a philosophical standpoint, is based on functional contextualism. The main premise is that psychological suffering, more commonly than not, although biological causes are not discounted, is caused by the encounter of the problem-solving logical mode of mind, of language acquisition that evolutionary happens over time, and more ancient sources of control of human behavior. And instead of trying to eliminate the unpleasant feelings and thoughts or body sensation, the ACT approach suggests that a more productive way to assist in emotional suffering is actually teaching new ways, alternative ways of operating, which in ACT is referred to as flexibility processes. And so if the traditional cognitive behavioral approach would aim to challenge unhelpful thoughts, for example, or feelings, according to the ACT approach, the effort is more on proceeding towards what is valuable and meaningful, thanks to the new mode of learning, the flexibility processes, not necessarily challenging the unhelpful thoughts. And so this is a drawing that summarizes one of the most common metaphors that the ACT use to describe the approach. So if I recognize that the symptoms that I'm bothered by are really overwhelmed and are driving my action, on the contrary, the ACT approach would help me through enhancing psychological flexibility processes to change the relationship between myself and the symptoms, so that myself, or a specific dimension of myself that I will refer to, will drive my behavior, carrying over the symptoms that may never disappear. We may not be able to eliminate, but the drivers will no longer be the symptoms versus myself towards what is of value to me. The core concept of ACT, and I will list a few of them, the ones that I see more meaningful to me, and the ones that probably can be seen in an open dialogue with logotherapy more easily, at least per my view. One is that in the ACT tradition, is part of the human nature to have yearnings that we do need to satisfy in order to have a fulfilled life. One of them is self-directed meaning. So there is an explicit identification of self-directed meaning as an essential need, yearning as part of our human nature. And then the difference between pain and suffering. Pain, which are challenges of life, which is inevitable, and suffering, which from an operational standpoint is the product of fusion, so being very entangled with our symptoms, and experiential avoidance, so that symptoms drive my behavior rather than my intentionality towards what is of value. The other key concept of ACT is the concept of value that I see sort of in a way compared with the meaning of logotherapy. So ACT doesn't talk about meaning, talks about value. So values for ACT are chosen quality of behavior in which the quality we are seeking is intrinsic to the behavior itself, can never be fully achieved, for example, within a dimension of our life, work, family. For example, one value could be being a caring parent. So the value of being caring is really never fully attainable. We always need to tend to do better. Very different than goals that are very practical, concrete steps that, on the other hand, can be achievable. And then ACT talks about values construction instead of clarification. So different than logotherapy, the ACT tradition doesn't say the values are necessarily exist and we need to discover. So that's a big difference. In a way, is a personal identification, is a construction of rather than a discovery of something that objectively exists. So this is a major difference. And then the key point is this last one, that we connect with our values according to ACT with a part of ourself which ACT referred to as perspective-taking self. So is the piece of us, is the dimension of us that is able to not be entangled with symptoms. And really, we can discuss together about how close that can be with the noetic dimension of logotherapy. So the root cause of a psychological suffering or maladaptive functioning, according to ACT, is what's called psychological inflexibility or rigidity. And because ACT was developed and continues to be looked upon as a transdiagnostic approach, so it doesn't matter what diagnosis the patient has, but is a paradigm that suggests a modus of operandi across diagnosis as long as there is suffering and maladaptive behavior. If we think about our day-to-day clinical work, how common it is, very common, that a patient presents with what's called cognitive fusion, meaning very entangled with a symptom that can be manifested even in simple words by saying, I am depressed, I am anxious, as the symptom was defining the identity. That's very common, right? How often our patients are unable to pay attention to the moment, and how much, on the other hand, the attention is very strictly attached to either the future, worrying, or the past, remorses, guilt, and really unable also to stay in the moment and hold what there is in the here and now, both in terms of what life brings to them, but also here and now with the symptoms that they are bringing, and kind of bringing how often they want to avoid, and actually because of the difficulty to stay in the moment and holding, they go to wanting to avoid anything that can be painful and in the suffering. And similarly, this cognitive fusion with the symptoms refers also to the attachment to the conceptualized self, which is a terminology in ACT that really refers to the idea that we identify with the problem, with the symptom, what is accidental rather than what is substantial. And then often in our clinical encounters, values, clients don't know what they care for, they're not clear about that. And even if they do, it's very hard to inform their behavior according to them, often avoiding actions or acting with impulsivity, or avoiding by default situation just to avoid the suffering. On the opposite side, the ACT intervention is meant to enhance the opposite, so the psychological flexibility, which, if we see at all these points that I listed before as rigidity, the act would turn avoidance, or would help, would assist by changing avoidance into acceptance. So instead of avoiding, holding what is painful, bringing making room for the painful symptom, learning that doesn't define me. Turning cognitive fusion into diffusion. So rather than identifying myself with the symptom, I'm able to identify the symptoms for what it is, very different than myself, and me being something else. Assist in train the attention to flexibly move, particularly focusing on the present moment, where the ability to hold the symptom is important to then distantiate from it. And then the ability to be in contact with a different type of self dimension. So not the self as content, which is entangled with the symptom, but self as context, which I find is something that I think the ACT literature, in a way, learned from Frankl, I think, although it's not explicit say, but is that a self-transcendent dimension of self, the consciousness, sometimes they call it, that we can discuss more about that, but it's really that a grounding dimension of self that allows the observation of the symptoms, the distancing, the holding, and then informing behavior towards what is meaningful. And then ACT would assist in clarifying, and this sort of component until here would assist exactly in the openness and awareness of what's going on in the internal world, and then the clarification of what is meaningful and valuable, and then the assistance in making a behavioral plan, even very concrete, according to the values, so that active engagement happens. This is just another way to summarize the flexibility processes in ACT. ACT uses different tools, very practical ones, that sometimes I found that may be helpful as within, at least not contradicting with the logotherapy sort of perspective. For example, this is one of the very practical tools to assist in diffusion, so assisting to differentiate oneself from the symptoms, and very practically, and this is all very publicly available, to the public if someone, has interest. But it's a very small exercise. The client is advised to write on a very piece of paper an unhelpful thought, and already doing this is a physical distance from oneself and the thought, and then is invited to, rather than putting it away as we want to avoid that and eliminate that, to carry it with us in a pocket, in a bag, and in a sort of non-judgmental and compassionate way, holding and making room of it, while little by little differentiate and informing choices according to values rather than on that thought that is written on the paper. This is a tool for fostering acceptance, which is actually, if you read it, I read it as paradoxical intention, and actually, which is an exercise to face what we fear. And actually, this is an extremely helpful scholarly project that already put a link between paradoxical intention and ACT. So I found this extremely helpful. But this specific tool that they call practicing opposite, I read it really as application of paradoxical intention. And then this is an exercise that can assist in being in touch with that part of self that I was referring to as self as context, or transcendent self, or consciousness. So once the client is assisted and learns how to train the attention, so to stay in the moment, and diffusing, so distancing oneself from the symptom, this exercise invites the client to acknowledge which is the dimension of self that is doing all this in a very, again, very pragmatic and practical way. This is another tool that is used in ACT and assists in clarifying values, where clients are invited to, in open-ended fashion, write what are the qualities that they strive for in any of the dimensions of their life, and then helps to review the concrete action that they did display in a certain day, etc., and then see if the actions were considered in line or not with the value, with what they really care for, and if not, making a plan to adjust a commitment of action for the future. This is another ACT tool, very, very graphical, where the clients can be helped to, in their own word, identify what they value in a specific dimension, and then analyze how their behavioral plan is going in terms of what their values are and what they actually better not to do in terms of discordant behavior. Doesn't matter what emotions and thoughts they have. In a way, the unpleasant thoughts, emotions, body sensation are always considered within, without the expectation for them to necessarily go away, but coming with them as long as they move towards their value. So what I wanted to do is try to sort of stimulate a dialogue and see whether logotherapy and ACT, in a way, they can integrate together. And this is a scholarly project, was published in 2004, which already elaborated on why the two methods actually may very likely dialogue in a very productive way. So this is another a wonderful resource that from where I learned a lot. Theoretically, the centrality and the reference to meaning is evident, although there was that difference about meaning exists outside versus is constructed, that I think is helpful to elaborate more, but at least there is this explicit reference to meaning in ACT can sort of foster dialogue with logotherapy. And then I think both of them suggest what we now call a growth mindset. That is not a species, but the possibility that thanks to the dimension of self that doesn't depend on what we experience. Logotherapy is the noetic dimension. Logotherapy ACT calls that as self as context or consciousness. Really, we can make choice, and there is always a possibility to make that choice according to what is important. And I see that as a growth mindset rather than a victimization kind of fixed mode. The inevitability of difficulties and challenge, the acknowledgement from both parts that challenges are inevitable is important. The centrality of meaning and choices, with again that caveat that I think is substantial about the meaning existing outside and we can discover it of logotherapy, that I find extremely hopeful. And versus ACT is sort of uses the terminology again of constructures versus clarification. And doesn't really comment in any way about that outside ontological presence of meaning. And the attention to the small and the ordinary. So the uniqueness of the person, the singularity of the situation that is the main, is really reminded to us in logotherapy all the time, and it gives dignity back to the single moment and the single opportunity. The attention of the present moment of ACT, I think, embraces something similar, so that there is value in staying in the moment. And then the homeostasis versus tension. Both do agree that the goal is not health, is not really homeostasis, it's completely something the opposite. It's the tension, something towards something greater or different. For ACT is that quality of behavior that we want to strive for. And then from a technical standpoint, I find that the dereflection and attitude of modification that are the two techniques of logotherapy, in part sort of the logotherapy phases, could dialogue well with the techniques of psychological flexibility in ACT. So these are the 4 phases of logotherapy that have been schematized by Schulenberg and colleagues in 2008, and is part of the logotherapy tradition, right? The importance of distancing before moving into attitude modification, and then symptoms reduction and maintenance. And so the dereflection is really, thanks to our ability to self-transcend, allow us to move our attention away from the problem towards the meaning, stopping the hyper-reflection. And the attitude modification is made possible by those very substantial, hopeful ideas of Frankl that we can find meaning in all situations. Life has always meaning, and there is always a choice and an opportunity. But I see the psychological flexibility model and the ACT approach to foster them, and that's my last slide, fitting well with the 4 phases that were presented before, particularly as we move from distancing to attitude modification, because the psychological flexibility process of being in the moment and being open and aware to what we are holding in terms of problem can then, recognizing that I'm not the problem, can then allow that intentional distancing, and then the principle, guiding principle of the attitude modification that ultimately can lead to very practical goals. But I find this very compatible and probably able to assist the preparatory phase of the distancing, so that awareness and openness can then move to that intentional, again, differentiation. With this, I conclude. And we have a little bit more than 15 minutes. I would like, being a learner in all of this, open for question, dialogue, because again, this, I could talk more, but I'm really eager and look forward comments and learning from you all, thoughts about this or anything about integration with different paradigms based on your experience and expertise. So thank you so much for your attention. And I see.
Teresa, can you remove your screen so we could see you more? We don't need to share the screen anymore.
Yeah, sure. Okay, perfect. Is the screen down now? Okay. Okay.
I guess I'll mention something. Thank you, Teresa, for such a wonderful presentation. I've heard about ACT, of course. A lot of my students do, who are therapists, do say they use ACT and see a lot of connection between Frankl and this technique and theory. I never thought, and I wondered if anyone else found this. Frankl always says we are not the symptoms, so I wouldn't say I'm schizophrenic. I would say I have schizophrenia. But I never thought of saying when I say I am depressed, that I am owning that cognitive fusion that you mentioned. I never thought of saying, well, in saying I'm depressed, I'm actually owning that depression more, that it would be better perhaps to say I feel depressed. So I don't know if anyone else caught that, but I thought that was really very important and something I'm going to remember to even share with my students. The idea that when I say I'm depressed or I'm anxious, that's that's probably not allowing myself to separate from that and look at it more clearly. So that was one thought I had. And also, can you explain this self-directed meaning? It almost sounds like he's saying we create meaning, which of course would be very much against Frankl's perspective that we discover meaning. So what is this self-directed meaning?
That's why, thank you, Dr. Neal, for this question, because when I was referring to that, and I don't think I have the full answer, because I think that is the piece that is different, and especially because of the sort of specification of referring to value construction versus clarification, as there was not I have to say that reading more about ACT, I am hopeful because again, in terms of values, which is what enact is meaning about, the ACT doesn't say that meanings do exist outside and we discover them, but doesn't even say the opposite, what the, for example, the French existentialists would say, that there is no meaning and we kind of invent one. Actually, they the ACT literature explicitly say that they just don't say anything one way or the other. So there is not if I don't have mistaken, and please anyone that there is not an ontological sort of affirmation of absence or presence. So there is a vague, and I am with you in that. That's why I think that yes, there is a centrality, but there is a substantial, at least explicit difference in logotherapy, of course, and the ACT is not that clear and clear about that. So and self-directed, in the sense, the self-direction, my reading is that is the owning responsibly for what is of value to me, sort of an intentional individuation of what is that may be different from someone else, but there is I don't want to call it pitfall, because you have every paradigm, but there is not the sort of the clarity the logotherapy has, I think, that
Thank you. So yeah, it sounds like there's not as much of a clear understanding of meaning versus values.
yeah.
I'd like to return briefly to the idea of having emotions, or having a diagnosis, but not being a diagnosis. And the good news is that the American Psychological Association has reached the point, maybe 10 or 15 years ago, where they pointed this out to do as well, so that when we're discussing in the APA style manual, when we're discussing someone who has a disability, instead of saying they're disabled, we have to word it in editing work that it's a person with a disability rather than a disabled individual. In the same way with, we can't say they're an alcoholic. We say there's someone who has a substance disorder, or someone who uses substances. But anyway, that's an aside. But I think that is part of where Frankl's and others' ideas have really gone in the mainstream without giving credit to it.
Thank you. I see that there is Dr. Winters had a question in the chat. Should I try to answer that question? I see a raised hand. Dr. Winters asked if what can we take as logotherapists from ACT? I find that those practical techniques, or at least the staying in the moment, holding with awareness prior to the distancing and then the attitude modification, see that from personal experience and the attempts with the clients. Of course, I'm an ongoing learner, but I find easier to distantiate and modify attitude after that training of the attention to the present moment, the awareness, the openness, the holding. So I think that the attention training piece, we call it maybe mindfulness, but it's actually better calling attention training, because it can be, I find it very helpful. So that sort of the value, meaning, of course, if movement and the act towards it comes after that holding. And Dr. Al-Khoury, William, you had a raised hand before.
Oh yeah, thank you for noticing. I'm also a therapist. I have a counseling practice, and I use the ACT model. I love the ACT model. It is one of my core maps that I use, and I found bridges to so many different other modalities. I mean, even the idea of the identity, we can find that in Carl Jung, and he talking about, do we identify with the persona, or do we identify with the ultimate self, the collective unconscious, or even existential? We'll talk about the self as subject versus the self as object. Somatic therapy kind of gets into that holding space where we can sit with our symptoms. Or I'm thinking DBT talks about dialectical, and we could replace flexible with dialectical, and we have radical acceptance. Or I was thinking even motivational interviewing, and how we use that for values and building their commitment and their motivation. And also something that I really use is AA has the idea of the serenity prayer and courageous acceptance. And I use that as a meaningful attitudinal value. Sort of, can we make space and accepting the things we cannot change, but still have the courage and commitment to change what we can for the better? And that's sort of the serenity prayer of knowing the difference between what is in our control and what is not, which is also a stoic kind of attitude, a stoic philosophy. And so I found the ACT model to be huge as far as like a core map and guiding and navigating counseling. And I think you've done an excellent job in bridging it to logotherapy. And so thank you for that.
Well, thank you for your sharing your experience, your expertise. It makes me think that all these came many years after Frankl. So the more I reflect on these, at least ACT 40 years after, it is really this is in a way cannot bring back to Frankl. Yeah, I wonder whether if he didn't have that, didn't do what he did, and if the traditions would have moved to, yet as Dr. Neal was saying, with still some substantial differences. That, yeah. Mm-hmm. And then Dr. Doreen Francis is the question is it would be there a preparation, becoming aware about one's to set in this passive once the work cannot is concurrent be done. Am I aware of track here? I want to make sure I understand the question. It seems the ACT can be very successful once the work on attitude is currently done. I don't know. It's hard for me to think about strict phases. Does the question ask if the ACT intervention needs to occur before the attitude, or maybe if Doreen would like to? share the question if but in general, I would say the guiding principle of attitude modification, it is that you know, stemming from the understanding that choices are always possible, opportunities are always possible, and then a plan is done about how to inform actions accordingly. Any of the flexibility processing act could match very well, particularly if the openness and awareness is somehow already occurred, the engagement processing, so where clients are assisted in clarifying what is of meaning in that sense for them, and then a behavioral plan, and then see from a practical standpoint, how is that going? For example, I find the practical tools helpful in terms of but just because I am a visual and sometimes putting that in paper, so the practicality of the tools of app could fit well, I think, with the process of attitude modification, particularly in if the engagement and the engagement flexibility process of ACT could fit very well, because that's really when values are meaning is identified, and then behavior is shaped.
Yes, thank you so much. I mean, that is it. First of all, thank you for a wonderful, wonderful presentation. I am aware of ACT, and I've used some of it in my own psychotherapy. But I always feel that there's a preparation for any kind of work in psychotherapy. And that preparation is about attitude. Attitude is a core, I think, about any work that we do. I mean, what is one's attitude towards themselves and others? And what is the attitude towards coming into therapy? What are the expectations of psychotherapy when it comes to logotherapy? Logotherapy is an action-oriented therapy and philosophy. Frankl says right off the bat that one of the ways to find meaning is work, and you find and love and connecting with people and your attitude. Attitude is one of the third ways we find meaning. So unless we do the work concurrently with ACT to understand our attitudes, so how we think and how we feel and how we behave is manifestations of the attitude. So in order for us to this is what I believe, in order for us to do a work of acceptance and commitment, there has to be that preparatory work in attitude. What do I feel about accepting this? Do I want to accept it? What is the process that I need to go through to accept? Maybe I don't want to accept it, so and maybe I don't want to to do the work on acceptance because I haven't forgiven myself yet. I haven't forgiven others in my life. And so I feel that our attitude is so important in this kind of work. So my question was that would it be helpful and beneficial to do the work on attitudinal change and our attitude before we get into the acceptance? It's like before we get into the work in forgiveness. First, we have to know what is my attitude towards who I'm forgiving and what I'm forgiving.
Okay,
So,
thank you, Doreen.
sorry.
No, that's all right. We're running out of time. Teresa, would you like to respond to that so we can wrap it
Yeah,
up?
and thank you so much for clarifying. I think one of the helpful thing is that sort of from an ACT perspective, the flexibility process and their strengths would be sort of assessed so that we can have a better, exactly. And then in the therapy contract, you're absolutely right. The clients need to know what type of work they're gonna do. But even in the case conceptualization, according to ACT, the strength of the psychological flexibility would be assessed. And so let's say that a client already has a strong idea of values and meaning, and maybe a very weak ability to be open and aware. That may be, if the client is okay to embark in some sort of work that involves holding, which is, as you said, in every psychotherapy, the value, it may be a good place to start and then build on that strength. So it can be, I think, fluid depending on, and that's why it's not a manualized intervention, very different than other, because there is, you know, room for fluidity and flexibility depending on where the clients stand, based and there is a mutual understanding, and then moving, building on their strength, starting with what they are, assuming that there is some sort of agreement on the general type of work that, you know, in work is mutually consented to. Does that answer?
Thank you so much, Dr. Lanza. I'm afraid we're over time now. Perhaps there's a way to continue the discussion in one of our discussion groups, but it sounds like there's a lot to talk about. Thank you so much for your presentation. It's been wonderful.
Thank you very much to everybody. Thank you.
Excellent. Wonderful.